Great. Well, let's go ahead and begin. I know that there's a few others who will be joining us in a bit, but it's really great to see so many new faces as well as some of our regular attendees at Drexel's Global Education Colloquium. My name is Christy Kelly, and I'm one of the faculty members here in the Global and International Education Program, and really excited to have Dr. Rebekah Burroway presenting today in the series and our last speaker for the year. So we're very excited to be going out with a big bang. Lots of different topics coming together this week in her presentation. If you are new to the colloquium, welcome. We are excited to have you here today. If you'd like to just introduce yourself into the chat and chat your questions as we go, we'll save plenty of time at the end for conversation as well. Dr. Rebekah Burroway is an associate professor and the graduate program director in the Department of Sociology at Stony Brook University. She's particularly interested in the ways in which women are constrained from fully participating in their communities and the subsequent impact this has had on households and societies at large. Two key goals of her research agenda are to further the measurement of women's empowerment in innovative and creative ways, and to evaluate the consequences that gender inequality has on families and societies. Some of her findings challenge the prevailing notion that economic development is the key to improving well-being in poor countries. She demonstrates that the effects of women's empowerment are comparable to or larger than those of gross domestic product per capita. Inherent in much of Dr. Burroway's work is an overlapping interest in child health, since women typically bear the primary responsibility for caregiving and maintaining household food security. Understanding the patterns of inequality and malnutrition and childhood illness not only affects children in the present, but it has long-term consequences for the future as well, since healthy children are more likely to succeed in school and society. Thus, a large part of her research agenda also centers on understanding the reasons that some children are at higher risk of malnutrition, disease, and mortality, while others are shielded from such risk. Dr. Burroway today will be presenting some research from a couple of different projects, and we're excited to have her here today. I will turn it over to you.
Great, thank you. I am also really excited to be here today, and although I'm a little bit disappointed that I couldn't actually be physically present in Philadelphia, this actually allows more of my friends and colleagues to join, so thank you for being here. Like Christy said, I'm gonna present two different studies today that talk about some new and hopefully you think creative ways of measuring the impact of women's education, especially for global health inequalities. And these are actually two of my very favorite projects that I've ever worked on, so I'm especially eager to share them with you, and I look forward to your comments and your questions at the end. So here's the starting point for my inquiries about education. If you educate a man, you educate an individual, but if you educate a woman, you educate a nation. This pretty well-known African proverb summarizes succinctly an entire body of research that goes back for several decades that shows the overwhelming faith that we have in the power of women's education to bring about transformational change in entire societies. And it's that almost blind faith in women's education that is kind of the starting point for my inquiries. Women's education is heralded as one of the key factors for reducing health and other inequalities across the world, but actually there's still a lot that we don't know about how and why education matters, and especially for child health. So the first study that I'm going to share with you talks about multi-level modeling and the use of geospatial data techniques. And this study has already been published in Social Science and Medicine. So if anyone wants a copy, I'm very happy to send it along. And in this study, we focus specifically on child immunizations and in the country Nigeria. Most of my prior work is cross-national in scope. This is one of the first times that I'm focusing on one case study. But I will just say that the techniques that we use here have wide applications. I also want to recognize my co-author, Andrew Hargrove. He's a PhD student at Stony Brook. Also, he's on the market if anyone has a job for him. He did the really heavy lifting on the data analysis, and he made the maps that I'll show you in a few minutes. So first of all, why Nigeria? Nigeria presents a bit of a puzzle from a development perspective. In the last couple of decades, Nigeria has experienced this tremendous economic growth over time, much higher than other sub-Saharan African countries and on par with other lower middle income countries, which you can see in this graph that Nigeria is quite far above sub-Saharan Africa for a period of about the last 10 years. But the sort of broad-based improvements in health and development haven't gone along with those changes in GDP per capita. So the theory is that as GDPs grow, as economies expand, then there are trickle-down effects that improve population health. That GDP per capita contributes to educational expansion, to the expansion of sanitation systems and water systems and increasing food supplies. And all of those things should have trickle-down effects to improve population health for everybody. A rising tide lifts all boats is the saying. But if we look at some of these well-being outcomes like under 5 mortality, we see that this is actually not the case. That while GDP has been growing over time, that Nigeria is performing worse in terms of well-being outcomes and lagging far behind its counterparts when it comes to things like infant mortality, for instance. Here, Nigeria is the top line in this graph, and you can see that in terms of infant mortality, that it's far out of proportion to its counterparts and not what we would expect given rising GDP per capita. Here's another graph that shows us something similar, but this is percent of immunizations over time, and it shows you basically the same thing, that Nigeria is lagging far behind its counterparts when it comes to well-being outcomes, and this is kind of far out of whack compared to where they should be based on their economy. And in case you're curious, that kind of blip around 2009 is because the government had a concerted vaccination program at that time point, but obviously it didn't stick, right? There was a little blip for a couple of years, and now they're back down to sort of abysmally low immunization rates. So again, it's sort of assumes that these benefits will trickle down for everybody, but that doesn't seem to be the case. And the problem is that economic development doesn't benefit all segments of the population equally. And most scholars who compare GDP across countries, they don't look at the variation within countries. So if you're comparing GDP across countries, that doesn't say anything about how the wealth is distributed within, and it doesn't tell us anything about the real beneficiaries of that wealth. And besides that, we know that fostering economic development alone, it doesn't ensure that other human needs will be fulfilled. Some countries manage to achieve much better health than expected relative to their economic growth. Others perform worse, like Nigeria. And so this shows that really something else has to be happening other than economic development, that income is a really imperfect predictor of well-being. And so we suggest paying more attention to women's empowerment, especially if we want to understand the well-being of children in developing countries. Now, there are many, many ways to measure empowerment. There is a burgeoning literature on this topic, and this is one of the things that I'm devoting much of my career to, is how can we capture what empowerment is. But women's education is definitely the most common proxy for empowerment. And there's a number of ways in which education is linked to child health, and there's a number of levels at which it's linked to child health. So first, at the individual level, maternal education is probably the most well-studied correlate of child health. In fact, I read something recently that claimed that it was the most consistent and the most powerful predictor in all of public health research. But there's actually a lot of disagreement about the mechanisms. There's not a lot of agreement on exactly how education affects child health. And the most popular explanations are through employment income and the use of health services. So when women are educated, they're able to get a job outside of the home, they earn an independent income. And this is good for child health because we know that men and women spend money in different ways. There's quite a large literature that shows that across the world in many different cultures, that women are more likely to spend money on things that benefit family well-being. So if they have control over the income, then child health will be better. And then the other potential mechanism is that education brings more health knowledge and an appreciation for health services, so that educated women are more likely to use health services. And in this case, they're much more likely to have their children immunized. There's another body of literature that looks at education across countries. And in this cross-national literature, for probably over 25 years, if not longer, social scientists have been making a connection between female secondary school enrollment and a host of well-being outcomes: infant and child mortality, maternal mortality, immunization rates, fertility rates, HIV rates, you name it really. That female secondary school enrollment is a very established predictor of cross-national differences in lots of well-being outcomes. So what has really been missing, and where we come in, is an analysis that incorporates both individual and also contextual effects of women's education for improving health. So in other words, does it matter if a child's mother is educated? But in addition, does it also matter if a child lives in a community where lots of women are educated? As broad societal transformations take place, it's possible that more educated women may begin to promote the growth of public services. They can mobilize extra resources, and those things can help to satisfy their own needs, but also the needs of other people in the community. So it's possible that women's education has a dispersion effect, whereby when more women in the community are educated, that this is good for everybody. So we use multi-level models to try to see if this is the case. Using a multi-level model approach, we're able to look at individual levels of education and also average levels of education in a community. So in order to do this, we draw on data from the demographic and health surveys, and we use specifically the survey for Nigeria in 2013, which is the most recent wave. And we limit the sample to children who are between the ages of 12 and 24 months. We do this because this is common in vaccine research, and that gives us a little over 6,000 children in the sample. I'll just say that there is evidence that children in Nigeria receive many of their vaccines late. And so we did try some different age cutoffs, and the results were the same. So we stuck with what's typical in vaccine research. And the outcome that we are interested in is whether or not a child is fully immunized. And in order to be fully immunized, you have to have all of 9 recommended vaccinations. And then the key predictor that we're interested in, of course, is mother's education, and we measure that in years. But then we also wanted to try to get at those mechanisms, because we wanted to see if education affects child health at both levels, but then we also wanted to see how we can explain that effect. So is it because of employment, or because of wealth, or because of health services? So employment is measured simply as whether a woman has a job or not. Wealth is the closest thing that we could come to income. This is a measure of household wealth. And then hospital birth, whether or not a woman gave birth in a hospital, is a measure of the utilization of health services. Now, in terms of the community level data, this was a little bit trickier. There's quite a bit of national level aggregate data available for developing countries. There's not very much state or community or any other kind of aggregate level data available for any countries that are outside of the OECD. And so we created our own. And the way that we did this is that every child in the demographic and health services is matched with a geocoded primary sampling unit. And then we took those primary sampling units and using the software ArcGIS, we overlaid them onto a map of local government area borders in Nigeria. The local government areas are the third tier of government in Nigeria after federal and the state. And people who share a local government area, they tend to share schools and marketplaces and cultural practices and language. So it seemed like an appropriate measure of community. Plus, states were too big, primary sampling units were too small. So for both methodological but also substantive reasons, the local government area seemed to make sense. So we assign each child to their appropriate local government area, and this gives us 455 communities. Now, by aggregating the children in each of those communities, then we can come up with average levels of education, of employment, wealth, and hospital use across all of the communities. And in addition, this spatial analysis also enables us to create maps like this. Excuse me. So this map shows you the distribution of immunization uptake across Nigeria. And the lighter colored areas on the map represent the areas that are the most marginalized. The darker green colors on the map represent the areas where children are more likely to be fully immunized. So in those very, very light areas, the light green areas on the map, only up to 10% of children receive all of their vaccinations. Whereas in those dark green areas on the map, you have between 40 and 100% of kids in those communities who are receiving all of their vaccinations. So we can see that there's quite a bit of inequality even just within Nigeria. I'll show you a similar map, but this one is for women's education instead. Once again, this map reveals quite a lot of disparities in women's education across the country. And once again, the lighter colors are corresponding to the lowest levels of average education, and the darker colors correspond to the highest levels of education. So in the most marginalized communities, women only have 0 to 2 years of education on average, whereas in the most well-off communities, women have between 12 and 16 years of education on average. So on the one hand, these kinds of spatial disparities are really obscured by country-level cross-national analyses that treat Nigeria as one case without investigating the disparities within. And on the other hand, individual-level studies fail to account for the fact that vaccine uptake and also women's education are clearly concentrated in particular communities. They're clearly very clustered. And so multi-level models have the advantage of being able to both investigate the disparities within and also take into account this clustering that's happening. So now let me turn to the models and tell you a little bit about our results. So on the left-hand side, you will see the predictor variables that we are most interested in at the individual level and at the community level. Of course, education, the big one, and then the 3 potential explanatory mechanisms. I do want to just note before I show you the results that we understand that there are many, many things that can affect whether or not a child is fully immunized. And so we do take into account many other factors, things like not hospital use, things like household size, or whether or not you live in an urban area, your religion. We even take into account some regional disparities because it seems like there's a disparity between North and South. So there are a variety of other things that are in these models, but I'm just going to show you education and the mechanisms for the sake of simplicity. So first in model 1, we look at just the relationship between education and the likelihood of being immunized. And that plus sign there means that education, the effect of education, is both positive and it's also significant. So at the individual level, as mothers have more years of education, their children are more likely to be fully immunized. And in addition, on top of that, at the community level, if the average level of education, or rather as the average level of education of women in the community increases, the likelihood of an individual child also being fully immunized also increases. Let me try that again. At the community level, as the average level of education increases, then the likelihood that a child will be immunized also increases. So this is a really exciting finding, because it means that if you live in a community where many women are educated, that means that you're more likely to be immunized regardless of the education level of your own mother. This is above and beyond the education level of your own mother. All right, so can we explain that effect with employment or wealth or hospital use? So next we look at employment along with education, and employment doesn't seem to matter for immunizations at either the individual or at the community level. I actually have an entire paper that's devoted only to this, that's just about employment. So I'm happy to talk about that later if you have questions. And importantly, that education effect is still robust. It's still positive, it's still significant. So employment doesn't matter. It also doesn't help us explain why education improves health. So how about household wealth? Household wealth, along with education, they're both very important. At the individual level, if you live in a wealthy household, you're more likely to be immunized. And in addition, on top of that, if you live in a wealthy community, you're also more likely to be immunized. But that education effect, it's still there, it's still robust. So even though wealth is important, it doesn't explain the reason that education affects immunizations. Then in the last model, we look at hospital use at the individual and the community level as a measure of whether or not a mom utilizes health services, and then also the percentage of women in a community that are utilizing health services. At the community level, this doesn't seem to matter. At the individual level, if your mom gives birth in a hospital, you're more likely to be fully immunized. And that makes sense given the fact that vaccine regimens start at birth when so if you're in the hospital, then you're at least getting started on the right foot. So that makes sense. And once again, that education effect, it's still positive, it's still significant. So what we would expect if employment or wealth or hospital use were explaining the reasons that education affects immunizations, then we would expect that education coefficient to drop out of the model, that something would explain it away, and we don't see that. And again, I just want to reiterate this finding, that the effect of education at the community level is robust across all of the models. And what that means is that everyone benefits from the education of women in Nigerian communities. And now I underlined Nigerian because I want to sort of emphasize that this is one case. But in this particular case, it seems that education has a spillover effect or a dispersion effect, whereby everyone in the community benefits from the education level of women in their community, even the children of uneducated mothers. And that's the part that I think is really exciting. Another sort of takeaway here is that the mechanisms that we usually use to explain why education affects health, they don't indeed explain away the education effect, which leaves me with these questions. I mean, what is it about education? And especially, what is it about aggregate levels of education? What is it about this community level that's affecting child health? I'd be eager to hear your thoughts about this and your hypotheses about this in the Q&A. but I'm gonna keep moving on so that I can get through my second study at the moment. So the second study, excuse me again. The second study uses unconditional quantile regression, and I have to be honest, this is brand new for me. I'm just learning this technique. So this is very much work in progress, and I hope that I'm able to explain it in a way that makes sense. And this paper is with Kristen Choret, who is one of my colleagues at Stony Brook, and she is the first author on this paper. She is responsible for all the graphics that I'm going to show you, and she's also with us here today, so she can help answer any questions if you have questions about quantile regression. So earlier I showed you this slide when we talked about some of the previous research about women's education and child health, and now this is the starting point for this next study. You might recall that I mentioned that for over 25 years that scholars have found this relationship between secondary school enrollment and a host of well-being outcomes across countries. And the finding, I hesitate to say that actually it's rather taken for granted, that that's the frequency with which this has been found in the literature, that this relationship between school enrollment, especially women's school enrollment, and health outcomes has been rather taken for granted. And so we want to actually revisit this relationship. And we're going to do so looking at the relationship between secondary school enrollment and infant mortality across 153 countries from 1970 to 2016. We're using unconditional quantile regression, like I mentioned, and we're drawing primarily from data from the World Bank. Also, before I go any further, I'll just note that once again, we recognize that there's many factors that affect infant mortality. And so we do account for things like GDP and violence, democracy, trade, and some other things. Those are in all of the models, but I'm not going to talk about that stuff just for the sake of simplicity. So traditional cross-national research relies largely on regression methods, simple ordinary least squares regression for one time point, and slightly more sophisticated fixed effects models for longitudinal analysis. And the strength of those studies is that they're able to identify general patterns across countries. And so in that way, this is a really nice complement to the study that I just presented. Cross-national research is a great complement to the specificities of case studies. But the problem is that these models assume a common effect. So that is, they assume that women's education has exactly the same impact across all countries. They assume that the size of the education effect and that the direction of the education effect is going to be uniform across all levels of infant mortality. So, for example, before we got into our quantile analysis, we ran a traditional fixed effects model, and from that model, we plotted predicted infant mortality rates by female secondary school enrollment, which you can see here. And before I go any further, I will just point out that enrollment levels do go above 100%. This is because we're using gross enrollment levels. And gross includes total enrollment regardless of age as a percentage of the age group that corresponds to the secondary level. So gross enrollment includes age inappropriate children. You can have underage as well as overage children in that group. So this is why we can go above 100%. So you can see here that the slope of the line is negative. The education coefficient that comes from the model is negative, therefore you see a negative slope. As you move from left to right, the line falls. As education increases, then mortality declines. And this relationship is negative at all levels of mortality. And from this model, we estimate that if a country has about 75% of their girls enrolled in school, then there will be about 40 infant deaths per 1,000 live births. And the implication of this model is that if a country increased their enrollment by 25 percentage points, then that would result in a decline of infant mortality by about 5 deaths. And if a country increased another 25 percentage points in enrollment, that would reduce deaths by about another 5 deaths, and so on and so on. Okay. So the figure suggests that the size and also the direction of the education effect is consistent across all cases, which just doesn't seem plausible to us. Here's another way of looking at the same data. This time, instead of plotting predicted mortality, this time we're showing you the education coefficient across levels of infant mortality. Just so you know how to interpret the graph, the red line in the middle is 0. That means no relationship. Anything that's above that red line is going to be a positive effect, which means increased mortality. Anything below the red line is a negative effect, which means declines in mortality. And so traditional regression techniques produce one single coefficient for each independent variable that is mean-based. And that coefficient summarizes the relationship between the predictor and the outcome across all cases, across all countries, across all levels of infant mortality. It's an average. So the black line here signifies the coefficient that shows us the relationship between education and infant mortality. And you'll see that it is below 0. That means that the coefficient is negative, that education is associated with less mortality, which is in line with previous research. But the model only estimates one coefficient, regardless of the infant mortality rate. But what if I told you there's another way? There is another way, and the benefit of quantile regression is that it allows for the possibility that the effect of education could vary depending on the mortality rates that we observe. So this technique, instead of producing one coefficient across the whole distribution, this technique produces one coefficient per independent variable at any number of infinite quantiles as specified by the researcher. So this allows us to look at the relationship between education and mortality at all points along the distribution of mortality, and allowing for the effects to vary in magnitude and also to vary in direction. This is very exciting to me. All right, I want to show you the results of the quantile regression. So we conducted a quantile regression for each 100th quantile. So that means that the model produces 100 coefficients for each predictor, but I'm just showing you the results for education, and I'm only showing you a few selected quantiles, not all 100 of them. But this gives you an idea of the pattern of the effects that we find. As a quick reminder about how to interpret the graph, the red line signifies no relationship. Anything above it is positive, anything below it is negative. And that black line is our traditional, the coefficient that we get from our traditional regression equation. Now, each one of those colored dots then represents the relationship between education and mortality at specific points along the mortality distribution. So each of those dots represents that relationship at a particular quantile. And so quantile regression shows a pretty substantial departure from what we find with traditional regression techniques. We see substantial variation in both the size, but also in the direction of the coefficients, the education coefficients. So you can see the differences in sizes by how far the dot lies from the red 0 line. The farthest distance from the line means a bigger effect, and when the dot lies closer to the line, that means a smaller effect. And you can see the direction of the effect by whether or not the dot lies above the red line or below the red line. So there's a couple of things that I want to draw your attention to about these results. First, let's look at the tails. At the lowest end of the mortality distribution, this is where infant mortality ranges between about 2 and 8 deaths per 1,000 live births. And at these lowest quantiles, you'll see that the effect of education on mortality is very, very small. Those dots lie extremely close to 0, which means that at these levels, up until about the 20th quantile, education barely has any effect on infant mortality. Now, at the opposite end of the distribution, where mortality is highest, this is where things get a little bit nutty. First of all, at the highest end of the distribution, infant deaths range between 74 and 203 deaths per 1,000, which is a little bit hard to believe, that 203. And at the 80th quantile, that's the very, very light grayish dot. At the 80th quantile, again, you'll see that the dot lies extremely close to 0. And so again, at the 80th quantile, education doesn't really have much of an effect. Then at the 85th quantile and at the 90th quantile, now those dots lie above 0, which suggests that education is related to increased infant mortality. Now, Kristen and I have talked a lot about this, and we're still sort of puzzling through it. I don't want to make too much of it yet, because one thing I also want to point out here is that the confidence intervals for those point estimates are very wide. And the confidence intervals are those vertical lines that are surrounding each of the colored dots. And the wider the confidence interval, the less confident we can be about that particular point estimate. And also both of those confidence intervals cross the 0 line. So I don't want to make too much of that yet, but again, I'd be eager to hear your thoughts about this during the Q&A. So let's look specifically at this 20th quantile and the 80th quantile. Let's look at those in a bit more detail. So here we have predicted mortality again, and we have predicted mortality by level of female secondary school enrollment. And you have the 20th quantile is the blue line, and then the red line signifies the relationship between mortality and enrollment at the 80th percentile. So first of all, the blue line is very close to 0. That's because the 20th quantile is where infant mortality is very low. The red line is obviously a lot higher. That's because this is among the highest levels of infant mortality in the sample. But what I think is remarkable about both of these quantiles, the very, very low and also the very, very high, is that the trend line is relatively flat. That across all levels of female secondary school enrollment, mortality doesn't change a lot. The blue line has a very, very, very slight slope, but substantively, this isn't very much meaningful change, rather. Another thing that I'll point out is that this is actually where Nigeria lies. To be more specific, I think Nigeria is at the 81st quantile, but close enough. So Nigeria lies right in this area of high infant mortality, where overall levels of secondary school enrollment for women don't seem to be having much of an effect. And I think that we can explain this with the geospatial analysis, because the geospatial analysis revealed just how much inequality there is within Nigeria. And I think that the key there is that it's not about raising the overall level of enrollment for the whole country, but it's about the way that educational opportunities are distributed within the country. So it's not going to be that helpful if there are more women who are enrolled in schools in communities where the average education is already quite high. That's not going to be as helpful as if we get more women enrolled in schools in the marginalized communities. That's going to be more helpful and really change things in Nigeria, I think. All right, so let me take you back to the full models, and there's another finding that I want to draw your attention to, and this time I want to draw your attention to what's going on in the center of the distribution. So in the center of the distribution, this is where infant mortality is about 14 to 55 deaths per thousand. And this is where you see the traditional education effect. This is where you see the expected benefits of education. You'll see in this segment of the distribution that all of the colored dots lie below 0. That means that at these quantiles that education has a negative relationship with infant mortality. Even the confidence intervals are all below 0. And so this is what we are expecting based on all of this previous research. And I think what this means is that this almost universally acknowledged link between education and mortality is being driven by this cluster of countries at the center of the distribution. That this is where the effect is really strong. And so this part of the distribution is mostly responsible for the negative effect that we see in typical regression studies. Now, you'll notice that there is still some variation among these quantiles in the size of the education effect, and the 60th quantile has the largest effect on mortality. That's the turquoise dot that lies the farthest from the 0 line. So let's look at that 60th quantile in a little bit more detail. So here you have the predicted mortality rates again and broken up into the 60th quantile, and then here I compare that with the predicted mortality that we would get from our traditional fixed effects mean-based regression line. And so you can see here that the slopes in both cases are negative. However, at the 60th quantile, which is about 40 deaths per person, or 40 deaths per thousand, at the 60th quantile, the slope is much, much steeper. And so what that means is that actually traditional regression is underestimating the benefits of women's education, but only for countries that have about 40 deaths per person, right? This is only at the 60th quantile. Okay, here's the same graph, but I've added some quantiles for the sake of comparison. And I've already talked about all of these quantiles, but I thought that this would be a nice summary. And I know that this is kind of a lot to absorb all at once, so I'll kind of reiterate all of the main findings from the quantile regression analysis again. So starting from the bottom, the green and the yellow lines. The green and the yellow lines are the 10th and the 20th quantile. So this is where infant mortality is the lowest, and that's why those lines are hovering around 0. The y-axis is predicted mortality. The green and the yellow lines both hover around 0 because countries in those quantiles only have between 2 and 8 deaths per thousand. So the other thing to notice about the green and yellow lines, the 10th and 20th quantile, is that the trend line is remarkably flat. So substantively, that means that education doesn't really have an effect on infant mortality at those quantiles, that there's not really changes in predicted mortality even as school enrollment increases. Then the orange line, that is infant mortality at the 80th quantile. So now predicted infant mortality is quite high. However, the trend line again is very flat. So even at this high level of infant mortality, education doesn't substantively have a very meaningful effect. The predicted mortality rates are basically the same, even as female secondary school enrollment increases. Now that's in contrast to the center of the distribution of mortality, which is the 60th quantile, and that's in the purple line. So at the 60th quantile, infant deaths are on average about 40 deaths per 1,000. And the 60th quantile is where education has its largest effect. So this is where the steep of the line is the slope of the line is the steepest. And you can see that as education increases, that mortality declines quite a bit. And this is especially remarkable in comparison to the blue line. And the blue line is the traditional regression coefficients that we would get from regular regression, from an average-based regression. And you can see that the slope of the line at the 60th quantile is much steeper. And then that red line, that's the one that's a bit of a puzzle. This is the 90th quantile, where infant mortality is the highest, and where it appears that education has a slightly positive relationship with infant mortality, that infant mortality increases just a bit. Okay. Sorry, I just wanted to make sure that oh yes, one other important thing about this graph that I almost forgot. So lastly about this graph, I think that this graph actually makes it easier to understand how we would arrive at the findings from a traditional mean-based regression. Because if you can imagine taking all of these colored dots and smushing them together and making an average, you would probably get something that looks like that blue line. And this is exactly what traditional regression models do. They give an average of the relationship between the predictor and the outcome across all of the cases. So overall, this analysis, I think, suggests that things aren't always what they seem. This beneficial relationship between education and health is really taken for granted, especially in a lot of global health research and development research. But the relationship is just not as straightforward as previous cross-national studies suggest. Quantile regression produces a much more nuanced picture of this education mortality link by demonstrating that the effect of women's education is not consistent across all levels of infant mortality. And indeed, it seems like the expected benefits of women's education are mostly limited to countries in the middle of the distribution of infant mortality. At the lowest and the highest ends, the effect is either virtually absent at best or potentially adverse at worst. And the findings also suggest that women's education has a more complex relationship with global health inequalities than previously understood. And I think that the almost universal faith that we put in education to reduce health disparities is a little bit misplaced. And taken together, I think that both studies show that methodological innovations can complicate even very long-standing findings that are taken for granted. The Nigerian study on immunizations shows how much we miss when we don't carefully consider within-country inequality. And the quantile regression shows how much we miss when we don't, or when we assume that the relationship between education and mortality is uniform across all countries. Now, I started by telling you that there's still a lot we don't know about how and why education matters, and I still don't know. As for the how, the quantile regression really muddies this up. And as for the why, the Nigerian study doesn't show that education improves health because it works through employment or income or health knowledge. So if anything, these studies kind of raise even more questions than they answer. And I also started by telling you, or I also started by sharing with you this African proverb, which claims that women's education can transform whole societies. Is that African proverb supported by empirical data? Well, yes and no, because some countries do appear to be reaping the benefits of education, but others aren't. And I think this has a lot to do with inequalities within nations. And maybe that's where we need to be focusing more of our efforts. And that leaves me with just a couple of cautions in focusing policy advocacy on specifically women's education. Now, in Nigeria, focusing policy on women's education could put undue pressure on mothers when there are other factors that could supersede her ability to get her child fully immunized. So yes, it is absolutely important to provide education that'll demonstrate the benefit of vaccines. Yes, that is necessary and important. But the uptake of vaccinations is going to require more than that. It also requires the ability to access them, and this is still a formidable challenge in Nigeria. Access is a matter of traveling distance, but it's also a matter of vaccine supply, and it's also a matter of trained staff to administer them. And cross-nationally, education is not going to have the beneficial effects that we think it will if women are still prevented from fully participating in social life in other domains. Because of world society norms, women's education is spreading all across the world, but that doesn't mean that attitudes towards women and their roles in society have kept pace. So as long as women are constrained in other ways, their education isn't going to be enough to save the world. That's all I have for you. Thanks for listening, and I'm really excited to take your questions. Thanks.
Thank you, Rebekah. If we were in a room with you, we'd all be applauding and thanking you very much with smiling faces and sitting up straight. So I just want to thank you so much. I think there's a lot to discuss here, both in terms of your findings, but also in terms of the methodology. And I also want to thank you because a lot of us in the room are not trained sociologists or quantitative specialists. So I think you've given a really interesting conversational way of talking about things as well. There are lots of questions that have come in.
And I'm sorry, I think I went over my time. I'm sorry.
You're absolutely fine. For those of you that came in late, welcome. We have plenty of time for conversation. Also, I want to let you know that this was recorded or is being recorded, and we will have it archived in the next day or two and available for people to view again or to review the parts they haven't seen. I'm going to turn it over to Brian, who I know has been watching the chat, to ask a couple of the questions there. And if you have other questions, please feel free to chat them in. When we get done with those, we'll open it up to broader conversation.
Yes, so the first set of questions come from Stephanie Schleit, and she asks if you could expand on the reasons for increase in vaccinations. I believe it was in the first study in 2009 in Nigeria, and then why they went back down. And then also in that study, did you consider men's education and the effect of both parents being educated?
Okay. So there is the government had a concerted effort to embark on this vaccine campaign in recognition of the abysmally low vaccination rates in Nigeria, and also in recognition of the fact that this very much contributes to the high infant mortality rates in that area. But in terms of why it didn't continue, my understanding is that it didn't continue because of funding, because something like that is extremely expensive, and the funding wasn't there to keep it up over time. And so that's why you see a blip in the uptake in vaccines while they were able to provide that program. And then as the support for the funding started to wane, then you see a dip again in the vaccination rates. And then unfortunately, that has stayed pretty abysmally low over time. And then the second question, about men. So it's funny that you asked me that, because you're probably, I've been studying women's education for a really long time. And you're probably only the second person that has ever asked me that. A lot of times, I don't know if maybe it's because I speak in circles where it's predominantly feminist scholars who just say rah, rah women and just don't kind of take it for granted that we should be studying women. So it's a good point and duly noted. The reason that I don't include men in the analysis is because in this body of research, it's the norm to exclude them. And this has a lot to do with the literature that demonstrates that not only are women the primary caregivers of children, basically across the world in almost every society, but also the literature that I mentioned that says that it's women's control over resources and income that matter the most because they spend money differently than men. So it's pretty common in this line of research to only focus on the women, but duly noted, and maybe in future papers I need to include those fathers as well. Oh, another thing that I will say on kind of a practical logistical note is that unfortunately the data on fathers is not very good in the demographic and health surveys. So another reason to not use it is that it really, really cuts your sample size down substantially because there's just not very good data from the fathers, and that's because in a lot of countries the DHS interviews specifically the mothers. So that's another reason.
Thank you. So the next set of questions is targeted towards the second study you discussed. So first, from Quantile Low, you mentioned that in marginalized communities, women have 0 to 2 years of education, and well-off communities, 12 to 16 years. So what is the turning point or benchmark to consider someone educated in that?
Yeah, that's a good question. And I don't exactly have an answer for that. So there is a lot of research that focuses on secondary school enrollment. And I think that the implication from all of that research is that it is the secondary level that is the cutting off point. I haven't done a lot. I have done some research in trying to investigate, does it matter where you do the cutting off points? And really it seems to me that it's not as much about a cut point, like now you're educated and now you're not, but it's more like more is better. So that's why we measure education in years, because it just shows that as it increases, then health is better. So I don't think that there is necessarily a cut point that says now you're educated.
Okay. Good. So next, coming from Nicholas Wilson, he says 2 ideas. 1, could the relationship at low levels of mortality be from a saturation effect of women's education, which is to say that the effect of education topped out there? And 2, at the other extreme, one could plausibly argue, glancing at the map of high infant mortality countries, that women's education in a place like, say, Afghanistan, exposes one to social stigma and even political violence. So could this have an unobserved effect on the relationship?
Sure. Kristen, do you want to chime in here? I think it's possible. We're still working through this. These are really good suggestions. The saturation effect is maybe very possible. I guess we would have to look at we would need to look at the specific cases, right? It'd be helpful to look at the specific cases and
Yeah, so I will. So since you invited me to chime in.
Please. Yeah, I invited you for a reason.
So I do, yeah. So Nick, I think that's exactly what's going on at the lower end, because, right, you can only reduce mortality so much, right? It's not infinitely reducible. It has a lower bound of 0. And so when you get into that range of single digits, there's just not that much space to make change for any reason at all. And yeah, on the high end, Rebekah and I have been trying to think about what explains potentially positive effects, although the the strength of those relationships is fairly weak. The confidence intervals are enormous, and we keep coming back to things like there's just so much, there's so many obstacles, maybe, you know, there's so much stuff going on in those areas that it's, I think, impossible to pinpoint any one thing. But I do, you know, that this is something we hadn't considered that I think does make quite a lot of sense is not just, right, we control for political violence, but we don't, right, that we don't control for that, right, the fear of being a target of violence as a result of pursuing education, which makes that I actually, that's a great,
That's a good idea.
that's a great, helping us make sense of that.
We aim to please.
Exactly.
Okay, so next, from Stephanie Schleit again, for the mortality rate over female secondary school enrollment, can you elaborate on the N? And second, do you know how women's education is correlated to individual and community wealth?
For the second study?
Yes, these are for
the second study. What's the sample size?
Yes.
Okay, yes.
On the sample size.
So we have 153 countries, 1970 to 2016, which gives us 3,000 some country years. 3,000, I don't remember exactly, but over 3,000 country years. And then what was the other question? The correlation between?
Correlated, how is women's education correlated to individual and community wealth?
In the second study?
Correct.
Well, I don't know, because in the second study, I only have country level data. Okay. So I can't say anything about how it's correlated with community level or individual wealth for the second study, because with the quantile regression, we only have data on countries and that's it. Okay.
And then from Lisa Kim, this is our last question online for the moment. For immunizations, I'm assuming this goes back to the first question, first paper. Was the distribution different for half the amount of immunizations? Did the light blue and green colors go darker?
So I think the question is, are there lots of children who get some of their immunizations? The answer is yes.
Okay.
I think that's the question, right?
Yeah, so
we chose to make the outcome whether or not you're fully immunized, because the emphasis is really in getting all of your shots, right? There is a reason that all of them are recommended. And in order to really have protective health benefits, you have to have all of them. So this is why we chose to make the outcome variable fully immunized. But for sure, there are lots of kids in Nigeria who get some of their shots and not all of them. Absolutely, yeah.
Okay, great. So that's those are the questions posted online now. I'll keep an eye on there, but I'll turn it over to Christy at the moment.
Sure. I mean, we do have a couple minutes, so people who had questions they wanted to open their mics and ask. And I actually have one myself, and that's what's next. Where do you see this going, and what are your priorities in terms of next research?
I mean, Kristen has really turned me on to this quantile regression. I kind of feel like, oh, what have we been doing all of this time? Even though I don't want to denigrate cross-national research, because there's a lot of it and it's really important. And it is important to know the big patterns. But she's turned me on to that quantile regression, and I already have another idea for a paper looking at the effects of democracy on child health using the same technique. We talked about that yet? Kristen, I'm already roping you into another project. So
yes, we already decided that one's worth giving a go.
Yeah, so that one is on the docket. And I don't know, to be honest, when it comes to specifically this education question, there's a lot more that I want to investigate about the how and why education matters, but I just am not sure how to do it yet. So the other papers that I have in progress, they have more to do with other aspects of women's empowerment. have one on specifically control over income. I'm trying to do some multi-level models on control over income. What happens if your mother controls the income? What happens if there's lots of women in the community who are in charge of the income? And I'm with one of my grad students, I'm working on something that's a bit of a departure from me. It's about attitudes towards the LGBT population, but it's in my wheelhouse in that it's multi-level models, but substantively is a little bit farther afield than what I've been working on recently. Yeah, what else? I also, oh, I know, the other thing that I'm really jazzed about at the moment is these geospatial models, and Andrew and I are also working on some more of those, but specifically about water access and about how his dissertation is about water access. And so the next one with him will probably be Nigeria again, but disparities in water access across the country. Yeah, those are some of the things that I'm working on. And if anyone has ideas about how to get at this, the how and why of education, I'm happy to hear it, because I don't know, I kind of bang my head over this. There's just so much literature that shows that women's education matters, and there is not agreement about why. And actually, one of the things that Kristen and I talked about is that the quantile regression might shed some light on why so much of the literature disagrees on the mechanisms, and it could be because education is operating in different ways in different countries. So then of course you're going to come up with a body of literature that disagrees, because the literature on the mechanisms is primarily case study based. So this study shows that in this country, education matters because of health knowledge, but in another country, someone else shows that education matters because of control over income, and they all disagree. So I tried to put them together to test for a general pattern, and I'm just not finding it. And maybe it's because of what we see in the quantile regression, that there's not an agreement because there's not a consistent pattern everywhere, maybe.
Sounds like context matters in quantitative and qualitative, right?
Yeah, for sure. Yeah, for sure.
Well, maybe some of our doctoral students in our School of Ed will connect with you and kind of think through some different ways of measuring this or studying it or trying to account for the variation.
Yeah, that would be great.
Yeah. Well, I want to thank everyone for coming today. We will officially close the session in terms of the fact that it's been recorded. And then if people want to stay on for a little bit more informal conversation, we can go ahead and do that. But I want to thank you so much, Rebekah. I heard you speak at the UN, where I think finding ways of making research accessible is really one of the biggest challenges. And I really appreciate your giving up your time today, as well as your expertise to speak to this community and to welcome everyone to our Global Education Colloquium. We hope to see you back next year. Thank you.
Thank you. Thanks.